Hi, this is Brian Kim. I want to share with you this case of a patient who had a dislocated IOL in the vitreous space. And this patient, through a vitreoretinal surgeon, had a pars plana vitrectomy, lens removal, and was left aphakic for me. And so this is the ideal setting to try my modified Yamane technique using the Sensar IOL. So those of you who are on the learning curve or considering learning how to perform scleral fixated lens implants in the context of no capsule support, this is really the setting to learn this technique. And so you can see the patient's aphakic, and I'm using a Wexel to completely dry the conjunctival surface. Very important for the markings. So this is a fixed caliper for the Yamane technique, which was developed by Epsilon for me. And you're going 2.5 millimeters posterior to the limbus and switching sides, and the other side is a 2 millimeter, and I'm marking adjacent to that. You can see the mark didn't work, so I'm going to go ahead and use the end of a cannula that's been inked to make those very discrete and small marks. I'm using the cannula to find 180 degrees apart on the other side as well. Now here I can tell that it's not quite radial, so I'm adjusting my marks there. And then I'm going again back 2.5 millimeters posterior to the limbus with the fixed caliper, and then on the other side 2 millimeters adjacent. This is my paracentesis incision for externalizing the leading haptic, which allows me to execute the trailing haptic cannulation of the haptic. And this is the incision for the trocar. And this incision is to push my dispersive viscoelastic to coat the corneal endothelium, and then to hold the eye for my 3 millimeter keratoma incision. This is a 20 gauge Lewicky AC maintainer. And this is the Sensar lens. I'm placing it into the cartridge. You want to make sure that the optic is nice and seated into the cartridge on either side. You can see I'm pushing down, it's nice and seated, and the optic should bend convexly. The leading haptic should go straightened out through the barrel, and the trailing haptic should come out of the cartridge. Placing the cartridge into the barrel of the injector, you can see that the trailing haptic is sticking out. It needs to be swept over the injector. You can see just like that, sticking out from the side. And then I'm pushing the plunger down. And then this is a screw top injector. You want to make sure that it's pushed through. It's going to push onto the optic. And as you dial it out, you can see it's coming out from the tip. Bending the 25 gauge needle, the barrel facing to the right. You can see I bent it pretty close to the tip, because you don't really need a long needle here. Placing the lens into the eye, again, my assistant is delivering the lens. As the lens comes out, the leading haptic is docked on the bevel of the needle. I take over once the optic's coming out, and then I let the trailing haptic stay out of the eye. Now the lens is sitting a little funny here because it's getting caught on the AC maintainer. So I'm going to very gently just reposition the lens. I'm just grabbing the haptics very gently to position the lens so it clears the AC maintainer there. The leading haptic is stuck underneath the AC maintainer, which is okay. I'm just going to reposition the optic so that it's more planar. Pushing dispersive viscoelastic to again further coat the corneal endothelium and pushing the optic back. This is the right side needle. I'm bending it about 9 millimeters from the tip. You can see how I'm positioning the needle so that you can see the bevel. The bevel is facing towards me on the right side. And then the left side needle I'm bending at the hub and it's facing away from me. grabbing the incision with 0.12 forceps, and then I'm starting on the sclera with my right side needle, stabbing through the sclera at the first mark, tunneling 2 millimeters, diving straight back towards the nerve, and then rotating. And you can see that the eye was perfectly still, the marks were not distorted, which means that the conjunctival marks should reflect the intended scleral needle placement. So you see that this is a little tip. You just pull the leading haptic out of the eye more, and it helps slide over the trailing haptic for better exposure. It pushes the optic away, so you have better exposure for cannulation of the trailing haptic. So you can see here, I'm very carefully docking the haptic on the bevel of the needle, and it goes right in. Disengage the needle from the syringe, and then using microforceps to internalize the leading haptic into the eye and having it sit in the angle. And remember, I'm just holding the eye in the neutral position. I'm stabbing through the sclera, going 2 millimeters, and then diving back towards the nerve, and then rotating, swinging it over. You want to make sure you clear the ciliary body to avoid any bleeding. And then the leading haptic should be pretty easy. I'm going to go ahead and try to grab the tip. And then again, you want to dock the haptic on the bevel of the needle. Make sure that they're pointing toward each other. Flatten it out, and then it goes in nicely. And then here, this is important. I try to pull the needles together just a little bit, but I leave the right side needle alone. I don't pull it out all the way as just a safeguard. And then as the needle's pulled out, I have my microforceps ready to grab it. It's very important. You want to be ready to grab it. You don't want to be fumbling around in case it's about to slide back in. So I cauterize the tip, and then I do the same thing on the other side. Again, unlike the CT Lucia, there's a lot more grip to that needle haptic complex. So in my experience, a lot less likely to slip out of the needle as you're trying to pull it out. Another reason why I love the Sensar lens over the CT Lucia lens. You can see here, I'm trying to push the cautery, but it's not quite working. So I finally repositioned, and it worked pretty well there. So now both sides have a flange, and I'm pushing the tips of the haptics flush to the sclera. You want to embed it into the sclera and then reposition and reapproximate the conjunctiva over it. So this is a 10-0 nylon suture. I'm going to go ahead and place it over my main incision. I always put in a 10-0 nylon suture in these cases. Whenever there's been vitreous removal, there's always a potential chance for vitreous coming forward, even though there's been a full vitrectomy. Let's go ahead and tie off the suture and then bury the knot. You can see there's a perfectly round pupil. This patient has done quite well. The lens is in perfect position. I'm going to go ahead and hydrate my incisions, take out the AC maintainer, hydrate all of my incisions, and that's the end of the case. So again, this patient had a dislocated 3-piece lens in the bag, the entire lens bag complex dislocated. She had poor zonules. And so a vitreoretinal surgeon removed the lens and did a pars plana vitrectomy and left the patient aphakic for me. And so I went ahead and did my standard modified Yamane technique, externalizing the leading haptic through a contralateral limbal incision with the use of a 25 gauge needle docking technique, which is a no-touch technique, so you're not grabbing the tip of the haptic and bending it and damaging it, which renders it useless to be able to cannulate through your 30 gauge thin wall needle. By doing it as a no-touch technique and docking it passively, as the lens is being injected, you're able to passively dock it on the bevel of that 25 gauge needle, comes out, and then you're able to execute the Yamane technique, cannulate the trailing haptic through the right side needle without any difficulty, because you're able to have the optic pushed away from you, which gives you great exposure, and more importantly, it doesn't cause much traction on the haptic itself. You want a gentle technique. These haptics are PMMA, and you want to have a gentle technique that allows you to cannulate the needle. And then again, you saw the principle of docking the haptic on the bevel of the needle, making sure they're parallel, and then flattening out the haptic, and then it cannulates real nicely. And then doing the same thing on the leading haptic with the left side needle. It's much more easy to execute the cannulation of the leading haptic through the left side needle second because the maneuvers are away from you. It's much more easy ergonomically. And you can see again, I docked the haptic on the bevel of the needle and then flatten it out, and then I was able to cannulate it nicely into the needle. You want to pull the needles out. The right side needle goes away from you. The left side needle goes towards you. And as you do that, you can see the optic rotating, but it's maintaining its central position. You don't want to pull the right side needle all the way out. You pull the left side needle, but then you have the microforceps ready to grab the haptic as it's being exposed and pulled out, and then cauterize the tip, and then do the same thing on the other side. Push the haptic flush to the sclera, reapproximating conj, and then closing. And so this patient did quite well. This is my standard modified Yamane technique performing the trailing haptic first modification. So I hope this was helpful to you, and I thank you for your attention.